Excellent. Good evening and welcome. Hopefully people are joining easily and can hear. Welcome to this new curriculum update for surgical trainers. As you all enter in, I'll just give you some great facts of the day. Obviously, it is the anniversary of the Apollo 11 landing from 1969, and when 1976 Viking went to or landed on Mars, and so that's obviously why Jeff Bezos has replicated space travel today. And just in relation to people's birthdays, in reference to the guitars behind John, is obviously Carlos Santana is 74 today. So without further ado, I'm going to move on and trying to get control. Yep. So on the webinar this evening, it's myself, Keith Jones, Surgical Director of the ICP, is Catherine Smith, who is Consultant Surgeon and Training Programme Director for Core Surgery in the East Midlands North. Catherine is going to show us a live demonstration of how they do the MCR in the East Midlands, and also grill John and I about the functionality and how we see the MCR working as we go live from August, and John being John Lund, Chair of the JCST. So I'm going to just go through some aspects. Obviously, I say obviously, if you've not done it, please go to the front page of the ICP. You can log into the curriculum and get all the curriculum details from this page. You can go to an introductory video related to the MCR, and we've also got pop-up videos that talk about the generic professional capabilities and the capabilities in practice. When you go to your dashboard, having logged into the ICP, to undertake a trial MCR, which you can still do before we go live and would encourage you to have done so, is accessible on the top line of the dashboard highlighted here. Once you go in, you'll note that the trial MCR has got watermarks that indicate very clearly that it's trial. It is the trial version. It won't be saved. There is a possibility to save its print version at the end, but you'll be asked to acknowledge this. Obviously, when we go live and you undertake the MCR, this acknowledgement won't be there. In relation to the approximate timings of when we see the MCR, so the multiple consultant report taking place, or asked about where it sits in relation to the placements. If I take that majority of people trainees will be on 6-month placements, looking at the midpoint MCR being around 2 to 3 weeks before the midpoint learning agreement, so towards the end of the 3rd month, with the midpoint learning agreement being at the beginning of month 4. And the final MCR being 2 to 3 weeks before the final learning agreement, which is likely to occur in the middle of month 6. And you'll see similar stagings for both those 4 and 12-month placements. This chart is again accessible via the front page of the ICP in the curriculum pages. No doubt, when you've logged on to the ICP, you've seen the great improvement in graphics that we've made over the last year. If I'll take you now to the phases of the training pathway, the changes that the surgical training will now be split into phases. Phase 1 is essentially, for the vast majority of surgical specialties, core surgical training and that level. Cardiothoracics, with their run through now, what would have been ST3 and ST4 are part of phase 1. Phase 2 for the majority, it's indicative of 4 years, and where the majority of the knowledge aspects of learning will occur. At the end of those indicative 4 years, indicative because it's what we expect the average trainee to take, you'll be able to take the exit examination in your surgical specialty. And then pass through into phase 3. Passing the exam is not a gatekeeper to going into phase 3. You go into phase 3, and this will be where the higher level surgical and technical skills are likely to be acquired. Again, indicative of 2 years. There's a slight difference in neurosurgery, that it's just it's just a year at phase 3. Your trainees at present, when they start their next learning agreement, they're going to be asked if they would want to be transferring to the new curriculum, and they will affirm if it's reasonable. What are these changes that will come in at the beginning of next month for your trainees? So from the 4th of August, and obviously this was delayed from last year, they'll start on a new curriculum that is outcomes based. Your trainee has the opportunity to progress at their own rate, i.e. they can go quicker if needed to. Or were able to, and this will all be assessed through the multiple consultant report, which is based on your judgment as a supervisor, and that is now the key component to the assessment. Within the assessment are the capabilities in practice. Within surgery, they indicate the end point of training, that's being a day 1 consultant in your specialty. Of equal weighting to those, the generic professional capabilities designed by the GMC and related to the old professional skills from the curriculum. The CIPs are assessed as supervision levels, as say, with level 4 being that of a day 1 consultant. Your trainees will undertake a self-assessment as well, which will be compared to the multiple consultant report when they're discussed, and obviously they then get or developing skills and be able to acknowledge their skill, where their levels are. The learning agreement will focus on the outcomes of the multiple consultant report. There still will be a very reduced number of work-based assessments, need to be rebalanced to focus on specific actions, either the critical conditions, which case-based discussions or KEXs, or PBAs for the index cases. And as I say, that training is split into three phases. So for transition, when will your trainees be transitioning? If they're starting new on either core or specialty training, they will transition straight at this time when they start. If they're moving to a new level, so ST3 to 4 or 4 to 5, they will start and transition on the new curriculum when they start a new learning agreement. So those people that rotate at the beginning of August, they will rotate and start with a new learning agreement. They've rotate in October, that's when they'll start a new learning agreement and transition. The exceptions are going to be decoupled CT2s that will stay on the old curriculum until they've completed that year, and then they'll go to the new for when if they enter higher surgical training. And for those people in their last year of training can remain. They can, however, choose if they wish, after a conversation with their training program director, to transition and show by undertaking the MCR that they've achieved their capabilities and competencies. Less than full-time trainees would transition at the next training level, taking into account pro rata time. But again, they also could transition earlier after discussion with their TPD if they felt that by utilising the MCR, they could show their competencies earlier, and therefore they may move quicker through the training programme. The CSER applicants can be evaluated against the new or the old curriculum, but they should consider now when starting that they must have completed and transitioned to the new curriculum by the 2nd of August 2023. So they think their journey is going to be a little longer than this, they'd be best off starting on the new curriculum. Well, my advice to trainees pre-transition, so the advice that you may give, is to ensure that all their previous assessments are signed off, that they would have undertaken a detailed self-assessment and utilised this as a gap analysis for COVID and related to the COVID-induced training gaps. And therefore, I've been encouraging all of us to recognise training opportunities, maximising training opportunities for the trainees and catch-up. I would advise the trainees to create a summary of all the work-based activities undertaken prior to August 2020 that provide evidence for certification, because those beyond that time, there already is a certification recognition, and utilise that list available for when they have their ARCPs. And any learning agreement they undertake should have the objectives of how to catch up the time lost to training from COVID. There is a new learning agreement that starts with the selection of a lead clinical supervisor and clinical supervisors, which then could be ratified by the educational supervisor when the objective setting meeting is undertaken. Once that meeting is undertaken, they can lead through to undertake the MCR. This is the assessment portfolio now. So there still are, as I say, PBAs, multi-source feedback, case-based discussion and KEXs. The trainees, when we gave this webinar, asked a lot about the differences between the MSF and the MCR, and were they both necessary? The answer to that is obviously yes. Multi-source feedback, utilising lots of other specialists, specialists and trainees to give feedback on one particular trainee. The MCR is the assessment by the consultant supervisors. As I just mentioned, the work-based assessments for certification are listed with a new certificate related to the trainees, accessible and visible at ARCP. The trainees will progress through the learning agreement. Once they've undertaken the objective setting, we'll be asking them to undertake a self-assessment, and this is when you as supervisors will be undertaking the MCR. The MCR is not driven by the trainees. It's the lead clinical supervisor that will be responsible for ensuring that this takes place, and we have been reassuring the trainees of that. What's in relation to the MCR setup, the trainee is going to nominate a lead clinical supervisor from their list of clinical supervisors. The objective setting meeting, that can be ratified. By that I mean that if one person ends up with 10 trainees as the lead CS, that this can be changed. The AS and the trainee will also ratify the clinical supervisors to ensure that as much of their activity as possible through a placement is recognised within and talked about within the MCR. The lead clinical supervisor, after that objective setting meeting, will organise an MCR, and that can be undertaken either a Teams meeting, a face-to-face meeting within utilising departmental meetings, local faculty group, or education groups. Certainly the feedback we've had from Champions Training is that education groups will be maybe formed in large units. It's really important that there is that face-to-face meeting, be it over Teams or within a meeting room of the clinical supervisors, and that we reckon that this will, after practice, take around 15 minutes per trainee. It's produced that joint report. Then there will be a 2-week period where you can feed back into that if you weren't able to be present, and at the end of which the AES can comment and highlight evidence from the portfolio. Then they'll sign off the MCR and a feedback meeting, dedicated session between the lead clinical supervisor and the trainee, or another nominated supervisor. This is how it looks now when we go live. The generic professional capabilities are assessed as appropriate for phase. That's the default setting. So if the trainee is appropriate for phase, it doesn't take long to pass through that. The capabilities in practice are assessed by supervision levels, and if you're assessing anything less than level 4, then you will utilise the descriptors or free text to show development. The GPCs, generic professional capabilities, designed by the GMC and the Academy of Medical Royal Colleges. There are 9 different GPCs, several of which have some subsections, all of which have descriptors. There's something like 240 descriptors, all written in the language of the GMC that you can utilise. But if a trainee is appropriate for phase, then it's just a tick in the box and they pass through, and it doesn't take too long. But this may be the information that you will want to be able to highlight aspects about a trainee that's very helpful in their feedback, and that makes a significant change to their training journey. And we're going to be interested to see how that is utilised. So say the GMC descriptors, so you don't have to make up or work out what you're going to write. You can utilise keywords, and you can actually search on those, such as time, and then you get the ability or time development action and utilise that descriptor. As I say, the MCR, the trainee will be doing a self-assessment. It's exactly the same as the MCR. They'll be doing it at the same time period. It involves their reflection and their honesty and assessment of their own level, and it will provide the comparison between the MCR and the crux and the basis of that feedback discussion between lead clinical supervisor and trainee. And to say the trial self-assessment is exactly the same as the MCR. The capabilities in practice, there are 5 core through all the surgical specialties. So the management, the outpatient clinic, the inpatient burden, be it through just straight management and the ward rounds, the management of the emergency take, the unselected within your specialty, management of the operating list, and that's global, inclusive of all aspects from the booking of the list, the WHO, through inclusive of the technical skills, but also the discharge planning and time and recovery from theatre, and multidisciplinary team working as well. They, in chiathoracics, paediatric surgery and plastic surgery, they have their own a single specialty specific CIP as well. The CIPs assessed supervision levels, and each time if you're assessing less than level 4, you may want to give feedback, or you will want to give feedback utilising points for development, but you don't have to choose 5 points of development. You can also highlight things that they do well, recognised by excellence. In this example, I think that where they taking comorbidities into account have been shown as excellent. Those supervision levels range from just observation only to direct supervision, so that's split into present throughout or present intermittently, to indirect supervision, such as when undertaking a clinic with a trainee and not seeing them until the end of the clinic, and then direct or the levels of a day 1 consultant at level 4. There is a level 5 which show excellence level above that of day 1 consultant. I show this helix. We use it in a lot of our presentations that shows about the MCR activity, starting from the top when it's set up, the meeting occurs. There is a 2-week period when the contributors can make comments, or those people that weren't able to action were able to make comments. The AAS can highlight aspects from the trainee's portfolio. We're not expecting clinical supervisors to have to have looked at or memorise the trainee's portfolio when they're undertaking the MCR. They're just giving an opinion about their clinical activities and work. The AAS can highlight evidence from the portfolio. And then the lead clinical supervisor will give the trainee feedback, and then it flicks or links in to the new learning agreement. So again, this is how it looks. Generate professional capabilities sets appropriate for phase. And the feedback that is given to the trainee is going to be comprehensive and relevant. We're hopeful it will occur at a regular basis due to the timeline. It's going to represent a consensus of our group of trainers, professional opinions. The midpoint assessment is going to allow for progression in the placement. The end point is going to show that that has been undertaken. Trainee is going to be able to look back and show their progression through timeline, as is the ARCP. And there is a large amount of comparison that can be undertaken. What I would say is review comments about the GPCs, the MCR when I've undertaken. The GPC 6 to 9 have got clinical aspects that you should concentrate as trainers, but as AESs, they can add in the additional comments related to portfolio, so that be it quality improvement or research or teaching. I would recommend that lead clinical supervisor really considers the global objectives and the progression through the syllabus of the trainee. It will help with the direction of the MCR. And it would be really ideal that the final MCR occurs just before the learning agreement completion, and then that can inform the ARCP. And we're looking that ARCP timings will be reconsidered, so they are occurring at the end of the placements. I'll touch briefly on time commitment. I'm sure Catherine will mention this, but there has been a large reduction in the number of work-based activities that are required and related to this version of the curriculum, and that offsets significantly, in fact more so than the time that's required to the MCR once it's down and you're comfortable undertaking this in approximately 15 minutes for an indicative standard trainee. Clearly it may take a bit longer for the more challenging trainee. I highlight there's been variable solutions that's come back on champions training that may be undertaken as how you're going to do it in a local area. The ideal is that the midpoint and the end of placement MCR are undertaken. The absolute requirement is that there's 1 MCR per placement. And remembering that this is a process that's driven not by the trainees, but by the lead clinical supervisor. And I highlighted, now this is one of our benefits slides that we put up at the beginning of our champions training, and the benefit of the MCR is highlighted in black to the whole process of the curriculum and the trainee. So they get high level outcomes that reflect the job of a day 1 consultant, and we're going to be ensured by feedback that the trainee is ready for independent practice, and they get lots of feedback to allow that development. That development takes into account the GPCs and the capabilities in practice. It's really important that it's based on our professional judgment now, and that's been re-established in the assessment system. So much back to the old apprenticeship system, using the best bits of previous assessment systems. And as I say, the trainee is going to get really meaningful feedback to allow them to develop, and where possible, they can demonstrate excellence. There are clear critical progression points that allow the trainees to pass through between the two phases, and that determine that those supervision levels are different in each of the curriculum, but they're shown in Appendix 4 of each of the curriculum. If you're going to read one appendix of your relevant specialty curriculum, look to Appendix 4 because it has all the certification levels in it as well. If you do undertake an MCR now just before go live as a trial, do please remember that when you get to the point when it says print it off, if you go to print for PDF, you can save this and upload it for the trainee into their portfolio. If you don't, it will be lost. And if you have any further questions about the curriculum, I run alternate week Teams clinics to cover all aspects related to the curriculum in the imaginatively named Ask Keith. So I'm going to now ask to switch to go to Catherine now. Thank you ever so much for joining us. Rather than go to questions now, we're going to Catherine's going to hopefully show us how they do MCR in the East Midlands, and show that what we've been describing is hopefully workable and true. Thank you very much, Catherine.
Thanks, Keith. Right, hopefully you can see my screen. So we've been doing the MCRs as a sort of trial probably for the last year in our unit, just to see how they work, and saving them and then uploading them separately to the trainees' portfolios. So this is a fake one that we're just going to run through kind of live. So in terms of when do we do them, we've been doing them so far at the end of each placement, so every 4 months for the cores and at 6 months for the registrars. We try and get as many people present for them as possible in terms of the consultants of the unit. So in terms of when do we do them, we try and do them at the MDT, where we've got a number of different consultants present, or if you've got a divisional day, then people are sort of freed up from their clinical activity, or if you have a regular team meeting when you're all together, that's the time to plan these roughly at that time when your trainees are about to leave you, is what we're doing at the moment. Hopefully, as we go forward, we can start putting in that middle one as well. So this is the first page, and when your trainee asks you who their clinical supervisor is, the answer from now on is everybody. So they need to put everybody down on their portfolio, so you can select the ones that present. So you just basically click the people who are there for the meeting. If there's somebody that they haven't selected but it's actually they're discussing them, then you can just invite them here. So if I were just to put in one of the names of my colleagues, then you can add them down at the bottom, and then they're involved in the meeting as well. And as Keith was saying, there's 2 pages to this. There's a professional capabilities is the first page, and then the second page is the capabilities in practice. So we take one at a time. The professional capabilities, circle of doom. I'll wait for it to come back, but chat in the meantime. So professional capabilities is, as Keith was saying, they all default to appropriate for phase. So if there's nothing particularly excellent or bad, then you can just leave this as is, and the trainee will pass through without any issues. But if there are some areas that you want to note, then it's nice to put them down. So the first one's really just, what are they like as a colleague? Are they honest? Do they have integrity? Are they reliable? Professional skills ranges from, are they literate? Can they communicate? Can they document? Can they come up with good management plans? Professional knowledge is, are they up to date? Do they participate in their appraisals, etc.? Health promotion, are they aware of management of alcohol, mental health, other addictions, etc.? Leadership and team working, so how do they run the team when they're on ward rounds, things like that? Do they keep things together? Capabilities in patient safety, quality improvement, so if they've done any good quality improvement projects that you've done together, then it's worth mentioning those there. Certainly we've had some registrars who've done some really good projects that we wanted to mention specifically. Safeguarding, are they in those vulnerable groups? Are they aware of how to identify and how to support those? Education and training. So in here we've put things where I've seen registrars being particularly supportive in training junior surgeons in theatre, for example, then they should get a mention in these areas. And if they've got particularly strong academic portfolios, and that can go in here, and how they interpret and use research and other things in terms of determining how they advise patients. If you're not sure what these are, then I suggest you just look at the descriptors, and it will give you some cues as to what sort of things they're asking for here. If you click something here, it automatically changes this to, let me get rid of that. It automatically changes this to an area for development, as you'll see, and it will specify what that area was there. If I take that off again, then you have to go back to this. If you want to free text it, something particularly good, you don't have to click this at all. If it's something particularly that they need to work on, then obviously you'd write it in there. So it's fairly self-explanatory, but again, if you feel they're going along quite nicely, then you can just leave that and move on. So the capabilities in practice is where those supervision levels come in that we've been practicing a lot in the last few years, I suppose. Each section is really the whole package. So when it comes to the outpatient clinic, it's history, examination, appropriate investigations, documentation, letters to the GP, follow-up, further management. It's the whole package. What's the supervision level? Managing the unselected emergency take, again, it's recognising those sick people, history, appropriate tests, communicating to patients and relatives, getting them to theatre, doing the procedure, post-operative care, discharge planning. All of that is encompassed in this second one. Ward rounds, again, are they a good leader? Are they keeping the team together? Are they identifying post-operative complications and acting appropriately? Are they doing the proper discharge summaries and making sure the follow-up's arranged? Managing an operating list. So again, this is the whole package, but I think in reality we don't. The trainees don't tend to book patients on our elective lists yet. Some of them don't get to the who moment on occasion if they're busy doing the ward round. So it does highlight things that we can perhaps introduce into their training, but it is making sure the list runs smoothly, actually does the operation, or how they are operatively is where you can put those sort of things in this box. If they are above average technically, then that would count in this section. And then discharge planning again. And then multidisciplinary working. So it speaks mostly of being the multidisciplinary team. So putting on the appropriate patients for discussion, highlighting the issues, determining what requires urgent intervention, admin, communication to the patient, all comes into this. And this is highlighted for us that actually we probably should involve our trainees more in our MDTs. So that's been a good thing that's come out of this. When it comes to filling this section in, I find it easier to just go through the supervision levels first. So as soon as you click on one, it will show you all 5 at the top here, and you can just move down, giving them the section that you want, and it populates those areas, and then you can put your comments in afterwards. You can see it's moving along the different capabilities along the top here, so it reminds you what you're talking about. And once we've done that, you'll see the supervision level's been put in down the side, and now you can just write in your comments as what's particularly good or particularly bad. So again, I mean, we tend to write what we feel in our meetings, so there'll be lots of comments that we can tap in, but equally, if you're not quite sure what to write, or you know vaguely what to say, you can write the word up here and see if you can find the appropriate bit, or you can just click the ones that you want, that you think are particularly good or require development. And when you've done that, you will see it populates it down here, so it fills it out automatically. And then, of course, at the moment, you save it and then print it. But as far as I understand, I'm sure Keith will let us know, it will automatically save to the trainee's portfolio going forward. So that's how we've been doing it. And And we've definitely been getting quicker as time's going on. But I think the key thing is, if you're not sure what they want from these sections, is read the descriptors and read the GMC steers, especially on the professional capabilities, if you want to write something. I do think, even though you can just skip the first page, if they are pretty exceptional at certain things, it's nice to write that in to give them some credit for it. Right, so that's about it from me, I think, Keith. So we're going on to questions.
Yeah, no, fantastic. Thank you very much. Yeah, I can confirm the once the MCR has been completed, when we've gone live, it will be embedded into the next learning agreement. So next time, so that midpoint MCR or midpoint learning agreement, when the MCR has been undertaken, the educational supervisor will be able to see the MCR and the self-assessment sat side by side and for comparison, and then there can be reflection on the discussion and the feedback session with the lead clinical supervisor, and that can allow the development aspects to be planned and then embedded into the learning agreement that can be then assessed and acted upon by the next MCR. So the only time there won't be an MCR or self-assessment visible will be the first time the things are undertaken, so the objective setting meeting, unless of course the trainee has saved their own self-assessment within their ISCP in the other evidence aspect, and their trainers were kind enough to send on the MCR that may have been undertaken about them as a trial from their previous placement. But yeah, no, free and open to ask away from the questions that come through, Catherine. So
one question would be, what happens when there's disagreement in the room? So two clinical supervisors or two groups, one thinks they're good in theatre, one thinks they're not. So how do you approach that sort of disagreement?
So I'm sitting yet, so I'll kick off. So yeah, it's probably not unusual. If you've got it, what we want really is to have a discussion about each trainee in the room, and then come to an agreement about what supervision level they should be awarded in that particular area, and the feedback they should give. I think the real beauty of this is if a trainee is not at the level of a day one consultant, then the system mandates feedback. You have to write something to how to advise them how to get better in the next 3 to 6 months. And you know, so we're not very good at giving feedback in moments that's going to be better. But like you say, there may be a few people in the room and there may not be agreement even after discussion. So what you can do is write down those two things in the free text in that capability in practice or GPC area. The other thing is that sometimes, you know, most units like ours are really functional and everyone gets on very well, but there are apparently some units in the country where this isn't the case. And there may be sort of quite dominant personalities that tend to hog the discussion and override the opinions of colleagues. And there may actually sort of be groupthink developing where it's just easier to agree and go along with it in the room at the time. And to allow for this, we've got a 2-week period afterwards where you get an email saying that you took part in the MCR, and do you agree with with what's written in the MCR? If you don't reply, then the default is that you do agree, but you do have the opportunity there to write something else, disagree away from the heat of the moment, from the discussion itself, and write some additional comments. So there's 2 different ways that you can disagree, either in person if you get on, or not in person if you perhaps don't want to have another argument with that difficult colleague. And if there is disagreement, then obviously that has to be sort of resolved by the AES in the learning agreement meeting. But there is opportunity for disagreement, amicable or less so.
I think one of the good things about this is there's it's anonymized in effect, isn't it? It's because all of you are having this discussion. So if you were to write something after the fact from your email invitation, is that also still anonymized?
Yeah, it is. Yeah. And I think that's the other thing. So it's, especially with the generic professional capabilities, it's been really difficult to pick up those things that get trainees into trouble when they become consultants. So those sort of aberrant behaviors that are a little bit off trajectory. And part of that is we've not really had the language for it, and the WBAs don't really capture that kind of thing. And then I think the other thing is that people have been really afraid to make a comment by themselves, because there's especially increasingly accusations of bullying or undermining, and people have been very perhaps cautious about giving real frank feedback, not in a bullying way, in a supportive way. It's important to know where you are so you can, what you're doing wrong, so you can get better. But of course, this will be coming from a group of consultants, those people that trainees work with day in, day out, and it's their agreed opinion. And so, there is no personal attribution to it. It is Chatham House rules that you'll come to an agreement, and that will be fed back to the trainee as the opinion of the group of consultants with whom they work. And so the people are much less vulnerable to any accusation. It's very difficult to accuse a whole bunch of consultants of having a grudge against that particular trainee. And so hopefully that will make people confident to give constructive but frank feedback to people in the MCR where it needs to happen.
Great, thanks, John.
Sorry, Catherine. I was going to add in just on that point that in relation to the feedback, that all the trainees will be reassured that the feedback they're getting is designed to make them better. It's to allow them to develop. It's not, people aren't just putting it there because they want to have a dig. They're raising a point that's a way that they can develop. And so if that's picked up and there is a discrepancy, and people show that in certain circumstances, and that may be where they're working with someone that makes them nervous, there are points that they need to develop, and there'll be some strategies in relation to do that. So all in the trainees' benefit. We assess the trainees' professional GPCs, and one of those is their professionalism, and we as consultant trainers are displaying that professionalism when we make these judgment upon the trainees and feedback how they can develop.
Great, thank you. So another question here is the educational supervisor allowed to also be the lead clinical supervisor for the MCR?
Yes, they can be, but and we're asked this question a lot. The difference, they have very different roles. So you can undertake both those roles because they don't occur at the same time. In ideal, we'd be utilising different people, but we recognise there are going to be some units that, because of capacity or because of the structure that they base their education on, the education supervisor and the lead clinical supervisor are one in the same person, but they undertake really different roles. The lead clinical supervisor organises and leads that MCR meeting and feeds back to the trainee. The AES role is on driving through and piloting the trainee through their learning agreement. And so they're very different roles. So yes, they can be the same person. Ideally, we think they'd be separate people, but they can be both the same person. They're just different roles. Likewise, you can be an AES and be a clinical supervisor and take part in the MCR and give your feedback, but that's very different to your role as an AES as well.
Right, thanks, Keith. John, someone's asked, how many MCRs are ideal in a year?
Well, so in a year, it's probably about the placement, really. So if your placement is, we'll start with a 6-month placement, which I appreciate that some placements are a year, but let's start with the 6-month one. There's no point getting to the end of the placement, John Lund, and telling John Lund he was rubbish at the end. Tell him halfway through, give him some feedback about where to improve in the next 3 to 6 months, and then reassess at the end. So that midpoint review in a placement is really, really important for formative feedback. And you can change the what somebody does in the second half of the job. Say that you haven't got much exposure to clinic, and that comes up in their self-assessment, and also the MCR is about changing what they do to help them move on and to give them very specific feedback about their own learning goals. And they'll develop those together and bring those together in the New Look Learning Agreement as well. So everyone should go onto YouTube and have a look at the New Learning Agreement video and just see how much improved that's going to be. If you're in a year placement, then of course the midpoint's at 6 months, but that's quite a long time to go before getting some feedback. You can carry on down the wrong trajectory for some time. So I would have thought ideally once every 3 months for trainees is ideal. At the moment, as Keith said, the midpoint one isn't mandated, just because we didn't want things to fall over at the first hurdle. But in the future, I think that will be, and it's probably really valuable to give your trainees feedback at half time, and which will just help them get better quicker.
Right. Keith, so at the moment, the clinical supervisor report, the final one for the replacement, has to be signed off before the final AES report. So does the MCR have to be done before the final AES report can be done physically on the system? They're always running around trying to get clinical supervisor report done so they can be signed off.
Well, so the answer is a little bit of yes and no in relation to this, but essentially both of those are signed off by the AES. So the AES must know that they should not be signing off the learning agreement before they've signed off the MCR. So the MCR should feed into the learning agreement, and it is the AES that signs that off. That makes it available to the trainee and to the then available to the lead, the clinical supervisors, and then at the end before the placement, when they sign off the final MCR, that will allow the end point of the learning agreement to be signed off. And then that should feed into or generate an AES report that will feed into the ARCP panel. The ARCP panel is going to have access to the MCRs. It can see the previous MCRs. It can see progression. But yes, so the just to summarise, the AES signs them both off sequentially. If they do it the wrong way round, you can't then go back to sign the MCR off.
Okay. John, somebody wants to know, where on ISCP can I find a list of requirements for passing CT1 according to the new curriculum? Oh, Keith.
Let's ask Keith.
Yeah. Appendix 4. Appendix 4 of the core surgery curriculum. So just go to the front page of the ICP, click on the core surgery curriculum, go to the end, Appendix 4, and there are the certification requirements. If you're looking for any certification requirement for any of the curriculum, that's where you would find it.
Brilliant.
So go to the home page of ISCP, click on the big thing at the top that says surgical curriculum, scroll down until you find the curriculum that you're interested in, click on that, and there you go, they're all there.
Okay. Currently, the AES attracts PA time per trainee. If the lead clinical supervisor is organising this, how do we encourage them to do so without additional training time for them to lead it?
Right. So, Catherine, you've organised a few of these. How long did it take you to organise it?
I think the key is to do it in a time when you're already together anyway. So we're all there for the MDT anyway. This takes, once you get used to it, probably 10 minutes a trainee to go through at the end of the MDT. So it's fine somewhere in your unit where you're all together, like I say, whether it's the MDT or a divisional day or a team meeting that you have every week, do it then when there's many of you around, and it's not asking everyone to come to a place at a different time that feels like it's something extra. So that's probably the best way that we do it anyway. It seems to work.
Yeah, I mean, so as well, it's just kind of an email saying we're going to do the MCRs for these trainees in the before or after the MDT this week. I'll see you all there. You don't have to be there in person, of course. You can participate like this over Teams. So the actual lead clinical supervisor part of this just takes a few minutes. That you would be the person most likely to be just typing into the computer as the discussion happens as well. And then the AES role's different. It does attract some funding, but it doesn't necessarily make it through to AESs in all trusts as well, or not at the rate it should do. And it's very different across the country. But that's a role that does take more time to go through the feedback, to do the learning agreements, to make a sensible plan, to look at the trainee self-assessment as well. So that should have, well, the recommendations 0.25 of the PA per trainee. It doesn't always as I say, get through to people, but the CS role is much less. We don't control funding as well for educational roles. And so this is something that comes from the statutory education bodies, which are HEE and their 4 nations equivalents, which give money to trusts in the very generous block funding that's given to trusts per trainee. And so if you're not getting that, then the person to speak to is your Director of Medical Education and perhaps the head of school and then the dean. So if you're not getting that 0.25 of a PA per trainee if you're the AES, then do speak to somebody. It should be there for you.
Keith, what's the minimum number of trainers allowed for an MCR?
Well, the minimum number is 2 because that makes it multiple. And you may think that's quite low, but that recognises that there are some units where there are a smaller number of trainers. So that's why we chose it with just 2 to be the bare minimum number. We would be advising and suggesting that the best number is probably around 4 or 5 trainers to be giving information back within the MCR. Certainly those are the numbers that we aim for. Just as an aside back to the previous question, one work that we've worked at and other units have is that if you form an educational group, the people that are getting 0.25 of PA being an AES may be a lead clinical supervisor for another of the trainees within the group, and that's the way around that we've got to ensure that people are recompensed for overall their time in relation to training at an appropriate level.
And I think from that as well, if you have too big a group, if there's 12 of you who are on the same kind of unit together, then probably you might not all be able to chip in. So it's just like that group dynamics. At 6 to 8 is probably the biggest size for a functional group. 2 is the absolute minimum to do that. What I would say though, it's really important to try and get people around the table, or the virtual table, who have seen the trainee in action in each of those capabilities in practice. And the thing that comes to mind is being on take. So with rotas the way they are, there may be that several of you haven't actually been on the emergency take with the trainee that you're talking about. So do have a think and try and get the person being on take with. If there isn't somebody there, you can always invite them to comment after the fact through the add participant section, but they're just not there, so they can still comment later.
What promptings the lead clinical supervisor going to get to undertake the MCR now that it's trainer led instead of trainee led?
What prompts?
They'll get an email.
They get an email.
Yeah.
They get an email from the ISCP system. So they'll be nominated an ISCP as a lead CS, and then as you get towards halfway through the placement, they get an email suggesting that they start to think about making arrangements for the MCR. The trainee will get the same, start to think about doing your self-assessment.
Great. Is there now a minimum number of WBAs per year on the new curriculum?
No, there's not. That's one of those great things about the new curriculum, is that number that the trainees worry about so much of 20, or 40, 60, or dare I say it, in London it used to be 80 number of work-based assessments to be undertaken in the year. That's gone. The work-based assessment necessarily relate just to the critical conditions, and the numbers of those vary between the specialties. So, for example, vascular surgery has 3 critical conditions: abdominal aortic aneurysms, acute limb ischemia, and fulminant diabetic foot sepsis, for which a trainee would need approximately 4 level 4 case-based discussions, or CECSIDs. Now, and that's all well documented in Appendix 4 of the respective curriculum. The index procedures are chosen not because they're an exhaustive list of procedures that a trainee must have undertaken. The procedures that they should have mastered are discussed also within the CIPs and represented within the syllabus. The index procedures have been chosen by each of the specialties to represent the breadth of the curriculum, to ensure that they have the trainee has been able to undertake that to the appropriate level. And again, those are reduced in number significantly, so you only need to do a PBA for the index procedures. You still can do PBAs for non-index procedures, and you might do that as a directive or a developmental aspect out of the previous MCR, and you'll use that PBA to show that you've undertaken that development. But the numbers are significantly reduced. It's not an absolute number. Some of the curriculums, you'll find that those work-based assessments are spread out as to the development of competence over time, and in others, those small numbers of work-based assessments may just be required in phase 3.
Okay, John, someone here's worried that having all the consultants or having all the clinical trainers involved in this might make the registrars feel that they have to cover constant rota gaps in order to avoid negative feedback. Any comment on that?
Well, I don't think covering the rota gaps and doing extra is any of the generic professional capabilities or in the SIPs. You know, I think we do rely on, you know, hopefully be no pressure to do that either way. I don't think trainee, well, I've not heard that from any of the trainees so far. We've had lots and lots of meetings with trainees, lots and lots of concerns raised. That's never ever been one of them. Just everybody, you know, everyone's a grown up and everyone should behave like grown up. So when you're assessing people, you don't want to, you don't want to criticize them for not picking up the rota gap when they don't have to, and that would, you know, that wouldn't be right at all. But you know, I don't think it's a worry that a concern that I've heard from any trainee in the several thousand that we've had on our webinars and interacted with.
I know, and we've got lots of rota gaps. I'm sure everyone does, and it's never been mentioned that somebody has or hasn't filled those gaps in our experience of doing these. Keith, one last question. The system believes trainers are doing robust assessments and have a high quality of knowledge. Is this validated? Are there any other examples of this?
Well, so the MCR is based on research by Kate, I'm going to pronounce it hopefully correctly, Katie, and we've also done lots of feedback assessments on the MCR done through the various different specialties. We had to provide that for the GMC before we were able to validate the curriculum and get those through and pass to go live. So it's not just a whim that we've fixed upon. It is based on research and there's good evidence. And you know, if the questioner wants specific feedback, then do come on to Ask Keith, or we've got it in one of our frequently asked questions as well in relation to the evidence used. So it is based on a lot of research, and I'm absolutely convinced that people are going to find this really beneficial into the feedback that trainees get.
You know, it's not rocket science, is it? It's you have a chat about how someone's doing relative to the endpoint. Everyone knows what a day one consultant should be like. If you're not sure, have a look at the syllabus, because that defines what a day one consultant should be able to do. And then tell them how to go from where they are now, or tell them where they are now and how to get a bit better and head towards that. We all know what trainees should be able to do a bit better in the next 3 to 6 months. So, you know, it really isn't, it's like a lot of educational theory. It's stating the obvious really and wrapping it up in some longer words. So, you know, I think the thing about this is when you do it the first time, and, you know, I think it was the same for us in our unit, that it feels a bit weird. It feels a bit strange. It's new. The interface is new. The discussions you're having are slightly different and sort of around sort of different areas. But it quickly settles down, and I think one of the real pluses is it's really much more engaging than the WBAs. With the WBA, you do a little snapshot of that particular operation in that particular patient on that particular day. And what we're doing now is saying, how is somebody relative to a day one consultant, how are they managing the acute take? And if they're not ready to be a day one consultant, tell them why not and how to get better. And then that feeds into the learning agreement, which will say what they need to do in the next 3 to 6 months. And then crucially, when you have a look at the learning agreement, how to do it, what resources they need, and how and when will they do that over the next 3 to 6 months. So I never got any feedback when I was a trainee, and it never knew if I was any good or not. I sort of, you know, I got CCT, and being a consultant, I haven't been struck off yet, so I'm probably not doing terribly, but who would know? But I think that, you know, I would have got better quicker had somebody told me what to do and what I needed to concentrate on. So it's just really going to make that happen for everybody. And so we'll, I think, improve the experience, both for you as an assessor, because you can give your global opinion of the trainee, of the trainee's performance, and also as a trainee, because you can pick up what your own learning needs are from the self-assessment, and also you get feedback, which will be, I would hope, constructive feedback that just helps you get better quicker. So I think it's going to feel weird, you'll get used to it, and I think that you will see the big benefits soon.
We've got 4 minutes left and one last question that either of you can answer. It's a good one, I think. So can a trainee choose to exclude a specific consultant if they've experienced undermining or bullying behaviour from one in particular?
So the answer to that is that you can change you can add or remove a clinical supervisor anytime you want through the placement. But my other answer to that is I would hope if you were choosing to do that for those reasons, you would have highlighted that to your educational supervisor or someone else within that process that was acting as a mentor, so that could be dealt with appropriately and removed, because that would be inappropriate behaviour. And so that yes, I think the system would very much support trainees to highlight and shout out about that sort of unacceptable behaviour that would be occurring. And yes, there's a way for them to remove them from those supervisors so they're not giving feedback.
I guess that the key thing is to tell somebody if that's what's going on, because they could remove them, but then I could add them on again at the meeting. So
yes,
they need to tell
absolutely.
somebody if there's behaviour like that happening. The lead clinical supervisor needs to know about it so it can be addressed properly.
Yeah.
Great, that's it for questions.
Well, so there's one more, isn't there? Are there any slides I can share with my team on the changes? And yes, there are. So if you go to ISCP, click on the big thing off at the top of the home page to go to the curriculum. There's all the resources there that you need through links on that page. But also, if you go to YouTube and type in JCST ISCP, it will take you to our page, and all the curriculum, new curriculum videos are there in easy to manage slices, so you can have a look through that. This talk, this webinar, and lots more are contained there. Particularly useful, I think, are the how-to videos, where you can look at how to do the learning agreement, how to do the MCR, etc., etc. So it's all there. And if the questioner wants to email, I'm very happy to send out the Champions training pack to them for them to share with their colleagues as well, and anybody else that wants that for that. And also there is the Ask Keith things alternate Friday mornings over Teams. So and there is a prize still to be won for the question that makes Keith squirm the most. So it's still up for grabs, everybody.
Thank you very much. Excellent. Well, thank you very much indeed. Kathleen, thank you very much for your time and for the great questions, and for walking us through how the MCR is done live. John and I are very grateful for that. Well, thank you very much for their time taken to come online this evening. We hope it's been helpful. And as I say, on the roll, it's this Friday for 9 o'clock. Till 10 is the Ask Keith session, and then it's every 2 weeks, and I'll try to be available to help. But any other questions, please go to the ISCP YouTube channel, and that provides as much of the information as possible. But I hope everyone has a great rest of the evening. Thank you very much.